Hello, friends, and I hope you had a good Eid, and I hope you have all been able to attend the 8th edition of the Hyderabad Intensive Care Symposium. Today, in continuation with the reminiscences and my recollections of what paradigms have shifted in the last 20 years, where I have spent in this dynamic field of intensive care, I probably thought I'll speak about paradigms which have not so much shifted, where sound physiological rationale has not translated into clinical benefit, and we had to give up certain interesting concepts. One such interesting concept, which I have personally worked on, and then I've done a little bit of original publications on this, is about tight glycemic control. When I started my career in intensive care in 2001, the first Vandenberg trial was published, which said that intensive glycemic control or tight glycemic control with a target GRBS of 80 to 110 is associated with better survival among critically ill patients. That seemed, something that is very logical because hyperglycemia is known to produce a lot of complications in critically ill patients. But one of my mentors, one of my gurus, you may say, Dr. Vineet Nair at the Manipal hospitals, felt that this was too drastic to be applied for patients with deranged homeostasis. And we did a comparative study of looking at 80 to 110 versus 130 to 150 in those days, in 2002, 2003. And then we found that patients with the tight glycemic control tended to have more hypoglycemic episodes and probably stayed longer in the intensive care unit. This fact was subsequently corroborated by several other studies, including the NICE sugar, which said that 80 to 110 is a very tight target and cannot be safely practiced among critically ill patients, while we still have some scope and leverage to practice the tight glycemic control among surgical patients. The same thing applies to post cardiac surgery patients and other cohorts of patients. So, tight glycemic control, although a very good physiological concept, did not translate into clinical benefit, and more so, it was associated with adverse events among patients in whom this kind of strategy was followed. So, that's one paradigm which probably did not withstand the test of time. Another similar physiological rationale which had its limelight way back in 2000, 2002, 2004, but has slowly waned off is SCVO2. Ever since Emmanuel Rivers published his seminal paper about resuscitation among patients in the emergency room, so called early goal directed therapy, the SCVO2 became an integral part of markers of resuscitation to the point that we were targeting an SCVO2 of 70 and above for adequacy of resuscitation. Subsequently, we understood the importance of venous hyperoxia, that is, SCVO2 of more than 80% being detrimental or being a marker of poor outcomes among patients with sepsis and septic shock who required hemodynamic optimization. But trying to optimize SCVO2 by blood transfusions or by infusion of dobutamine was not associated with better outcomes among critically ill patients. So, the SCVO2, although is a physiologically strong principle, is a strong rationale, could not then become an integral part of resuscitation algorithms, although it still can be perceived as a marker of tissue hypoxia and uncoupling of the electron transport chain at the periphery. So when we spoke about blood transfusions, again, some paradigms which high hemoglobin, for example, did not again withstand the test of rigorous scientific scrutiny. Ever since the first trick paper published from the Canadian Critical Care Group showed that conservative hemoglobin target of 7 grams per deciliter are safe, they are not associated with higher incidence of coronary ischemia among a general cohort of critically ill patients. Several studies have looked at different subpopulations of these patients and have found that a more modest or a more conservative target of 21% of hematocrit, that is 7 grams per deciliter of hemoglobin, is probably as good as a higher target. Maybe patients with acute ongoing myocardial ischemia with cardiogenic shock may be a cohort of patients who will not be candidates for this kind of conservative hemoglobin targets. Maybe the pregnant lady, maybe the bleeding trauma patient. These are all not patients who will qualify for this low hemoglobin target, but overall, the general cohort of critically ill patients seem to be better off, seem to be safer, and seem to be unharmed by a conservative oxygen target of 7 grams per deciliter, that is a hematocrit of 21%. So, this paradigm that more hemoglobin means more oxygen delivery, which was also a part of the reverse algorithm, also has waned off and is no longer considered as standard of care in intensive care. Another interesting device, which actually was used quite often and was believed as a lifesaver among patients with cardiogenic shock, is the intra-aortic balloon counterpulsation (IABP). In the early part of 2000 up to 2010 and 2012, IABP was an integral part of the therapeutic process or therapeutic algorithm for management of patients with cardiogenic shock. But ever since the shock trial, the IABP shock trial showed that general cardiogenic shock patients with decreasing requirement for vasopressor and inotropic support do not benefit from the use of IABP. The enthusiasm about using this particular tool for optimization of coronary blood flow has slowly waned off. There may be a small cohort of patients who are in severe cardiogenic shock with very poor ejection fraction who may still need the transient support with the balloon counterpulsation, but it cannot be considered that IABP is an integral and a must do for all patients with cardiogenic shock. With the advent of ECMO, the veno-arterial ECMO, and more recently the availability of the assist devices, both the right and the left ventricular assist devices, probably seems to have pushed the IABP back further in the pecking order in terms of instruments and tools you choose to optimize patients with cardiogenic shock. Another interesting paradigm which has fluctuated to and fro ever since 2000 2001 till recently has been the use of steroids in septic shock. The original Annan paper recommended that 50 milligrams 6th hourly of hydrocortisone combined with fludrocortisone is associated with better hemodynamic profile, earlier weaning up of vasopressors, and probably shorter ICU stays among patients with septic shock. But as we followed this algorithm and as the standard of care for sepsis improved across the world, as the Surviving Sepsis campaign guidelines came to be standardized and followed more rigorously across the world, the benefit with infusion of hydrocortisone and specifically fludrocortisone seems to have waned off. Several studies were then published which argued in favor and which didn't support or did not give so much of enthusiastic reply or confirmation that steroids in septic shock are beneficial. But of late, we have seen that again it's back to a combination of hydrocortisone and fludrocortisone in the most recent COST trial, which says that probably a combination of fludrocortisone and hydrocortisone in the dose described originally by Annan is probably good enough for vasopressor sparing and shock reversal among patients with sepsis and septic shock. So that's one paradigm which is swinging like a yo-yo in the management of patients with sepsis and septic shock. Of course, we all know that a sound physiological or a pharmacological principle like activated protein C did not sustain the test of scientific scrutiny after the initial industry supported trials confirmed that it's a good tool to use in patients with sepsis and septic shock. Now, another interesting aspect where the paradigms have not shown to be of benefit or have not shifted or have probably not changed much has been in the use of bicarbonate in patients with metabolic acidosis. It has always been considered as cover-up operation, as a cosmetic response to a basic drastic underlying life-threatening problem that is metabolic acidosis. But recently the Bicar ICU trial raised a flag saying yes, you may have some improvement among patients with shock who have metabolic acidosis with the administration of Bicar ICU, but with the administration of sodium bicarbonate. But the point to remember is what was the end point which was studied in the bicarb ICU trial. The bicarb ICU trial looked at better bicarb and better pH. Yes, administration of exogenous bicarb does give you good numbers, does give you a good pH, does give you a good ABG. At the end of the day, you are left with good numbers, and a dead patient is not what we are looking for as intensive care practitioners. So, if your endpoint is shock reversal, if your endpoint is vasopressor requirement, if your endpoint is RRT requirement, and if your endpoint is ICU length of stay, then probably bicarbonate has not actually been shown to be of much benefit. Another area where a good intervention which has not been able to show comparative results when used aggressively among sick patients has been in the role of decompressive craniectomy in trauma, right? Then this paradigm is a little interesting paradigm because decompressive craniectomy in ischemic stroke has been associated with better stroke outcomes and better coma outcome scores than when compared to trauma. So in trauma, the the DECRA trial actually struggled to recruit enough patients. They overshot the recruitment period, but nevertheless, the finding has been a negative trial saying that decompressive craniectomy in trauma is not beneficial in patients with raised ICP. So, how does it actually all boil down to? It probably means that we haven't understood the pathophysiology of neuroregulation and cerebral hemodynamics as yet. The pathophysiology of traumatic brain injury is much different from the pathophysiology of an acute ischemic stroke, much as acute ischemic stroke differs from subarachnoid hemorrhage. So, these two cohorts of patients, that is trauma and acute ischemic stroke, probably differ a little, in their blood-brain barrier permeability and the auto-regulation being preserved versus the auto-regulation being deranged, and that's probably where decompressive craniectomy has not been shown to be of much benefit. Albumin is again something that has come in and gone out. People prefer to use it initially, but later on, the role of albumin has become confined to the hepatic and liver failure units. Whether you look at trauma patients, whether you look at septic shock patients, whether you look at any cohort of patients other than those with hepatorenal syndrome, large volume paracentesis, and acute liver failure, we could not be able to, we were not able to show much benefit with the use of albumin. So although it looks like it's a like for like replacement, you lose fluid, you replace it, you lose hemoglobin, you replace it, so you are low in albumin, you replace it. That somehow does not seem to be as simple as 1 plus 1 is equal to 2. So the waning off of albumin has been another paradigm which failed to impress and failed to register itself as a paradigm that could be transferred. Here I must say my disappointment with high frequency oscillatory ventilation in ARDS. During my initial stages as a practicing consultant, I was much impressed and enamored by high frequency oscillatory ventilation, and I was trying to convince the people where I worked to buy an HFO machine for adult patients with ARDS. But as I was able to succeed, as I was able to convince them and they were about to sanction the machine, came the two dampeners, the Oscillate and the Oscar trials, which one of them did not show benefit and the other one actually showed harm with the use of high frequency oscillatory ventilation among patients with ARDS. So, again, an interesting physiologically sound principle did not stand the test of scrutiny in a rigorous randomized controlled trial. So, the interest in while it still continues to be used in some pediatric cohorts of patients, its role, its presence in adult intensive care units has gradually dwindled down. Glutamine made a big name for itself in the initial part of the 2004. People said in burns it helps, in traumatic brain injury it helps. Some said it will regenerate your enterocytes, so your gut-brain axis gets preserved. And oral glutamine versus parenteral glutamine. At the end of the day, glutamine as an immunonutrient failed to show much improvement in the hemodynamic and vasopressor profile of critically ill patients. So that's another hypothetically good concept, that did not stand the test of scrutiny. But in my view, the biggest physiologically sound tool which gives you a bucket load of information which has not been validated, not been vindicated by a large positive randomized control trial is the pulmonary artery catheter. People still say it is the gold standard for hemodynamic monitoring. People will still compare all the new hemodynamic tools against the results of the pulmonary artery catheter. But ever since the Connor paper came, which came long ago, said that it doesn't make a difference to the outcome of critically ill patients, the pulmonary artery catheter has slowly found its way out of the intensive care unit, the general intensive care units. Although the specialized cardiac care units may still use the PA catheter, the information you get from it is very tangible, very sensible, and actionable. But as a tool, its role has actually not caught on, and maybe the younger guys who are training in intensive care have not even learned how to float a swan. Yes, you can still get information from an echo. You can get some information from the PICO monitors, but the hemodynamic and the waveform information which we used to get from pulmonary artery catheter, and the interpretation as it progresses from the internal jugular vein right up to the west zones, was something which could make you revise your physiology and make a decision. But I think the decisions which were made based on the pulmonary artery catheter did not influence the outcomes among patients. So the tool became something that was considered as ineffective or not a good tool to be used in the intensive care unit. So these are some of the units aspects, friends, where good sound physiological principles did not stand the test of rigorous scientific scrutiny. So while physiology seems to argue in their favor, the clinical scientific research has not shown them to be effective, and that's the beauty of intensive care. A patient in the intensive care unit is a completely different physiology, is a complete different ball game, and that's where we as intensivists have to make personalized decisions, and that's what I think I have realized over the last 20 years. Thank you very much, and we meet again sometime later.